by the Gastro Foundation in association with Project ECHO, the University of New Mexico. These sessions are held every Wednesday. The chat will be open for people to post questions during the discussion, and there will be time for discussion after the presentations. So today we're going to be talking about LIRADS for HCC, a crash course for the non-radiologist. That's going to be presented by Dr. Segobin, and then we're going to, after that, have a number of case reports, and the people involved with that are going to be Dr. Subnach, Dr. Akambuli, Dr. Sekazin, and Dr. Leach. We're just going to give a little bit of time for more people to join the session. There is a questionnaire that was sent out before the session, and that's available, I think, in the chat. We'd really appreciate if people would just take some time to fill that in, just so that we can get a sort of an understanding of people's knowledge of the LIRADS system. It's quite quick and simple to fill in. So we're just going to wait a few minutes, and then we'll get going. Yeah, I think we should start.
Can you see my screen?
Yes, we can.
Okay, thanks. Good afternoon, everybody. My name is Rajshree Segobin. I'm a registrar in the Division of Radiology of the University of Cape Town, and it is a great privilege for me today to be speaking to you on this platform. And I will be talking to you and taking you through a roundup of what LIRADS means in the context and management of HCC. And this is intended not as a radiology lecture, so don't be worried, but more as a crash course and overview for the non-radiologist. And let me just see if my slides are progressing. Okay, so we are based at the beautiful in the beautiful city of Cape Town at the Cruz Care Hospital, as you can see in the picture. And this lecture is a partnership between the Division of Radiology and the Division of Hepatobiliary Surgery and the Gastrointestinal Society GI Hepatology ECHO of Sub-Saharan Africa. So what are we going to be doing today? I'm going to be taking you on a brief introduction on the talk during this talk about HCC and how LIRADS came into the picture of the management of HCC. And I'm going to give you a brief overview of the categories and algorithms of LIRADS and how they are important in the management of HCC. Some special considerations, some pitfalls, and the future directions in which we are heading with LIRADS. So why is LIRADS even important? So HCC, as we know, is the sixth leading malignancy worldwide. And of all these HCCs, about 80% emanate from low to middle income countries, and mainly in sub-Saharan Africa, where chronic hepatitis B infection, as we know, is a leading etiology with mainly non-cirrhotic livers. In the recently published systematic review by our institution, we could see that curative treatment, liver resection, transplantation and ablation has been offered to only 6% of the cohort. And in fact, the majority of patients, 84% actually, only receive best supportive care, with very few survivors at 1 year, which makes the need for improved surveillance of at-risk patients very, very important. Even more important, the timely diagnosis of HCC and the need to build up comprehensive data registries to further research and improve management of these patients. So this is where imaging comes into the picture. HCC is unique in that the diagnosis can be made exclusively with imaging. And this is why the structure and clarity of reports is often of utmost importance to clinicians who need to take day-to-day decisions about the lesions of patients at risk of HCC. LIRADS was implemented with the same idea in mind to standardize the reporting of HCC, and its main aim was to achieve near-perfect specificity for HCC diagnosis, termed as LIRADS 5, definite HCC, so that the need for biopsy can be reduced, if not eliminated, in these cases. The typical imaging of HCC, as we know, is enhancement on the arterial phases of triple phase CT, with washout, as you can see in the second diagram here, compared to the liver parenchyma. And on delayed phase, we often see an enhancing capsule present. And very typical for HCC compared to other intrahepatic carcinomas, such as cholangiocarcinoma, is the propensity to invade vascular structures. And on an enhanced MRI, one may see a slightly hyperintense lesion on T2-weighted imaging. So these are the classical findings. But before we probe further into the very radiologist lingo, let me just clarify for those of you who might not be familiar with these terms, some of the imaging protocol terms. So what do we really mean by an early arterial versus a late arterial phase? This might not be clear to everybody here, but an early arterial phase is usually the timing of the study is about 25 to 30 seconds after injection of contrast. And here you can see the early start of the enhancement of the hepatic arteries, whereas the late arterial phase is the stage of maximal tumor, we call it, that is with very bright or hyper-intense enhancement of the hepatic arteries and the beginning of the enhancement of the portal veins, but there's no enhancement of the hepatic veins at this point in time. So HCC, being a very hypervascular tumor, will enhance more strongly in the late arterial phase and with early enhancement of the portal vein. But what about the portovenous phase? Portovenous phase, as you can see, if you compare the normal liver parenchyma to the arterial phases, this is the stage what we call the max liver parenchymal enhancement. And this is the phase where you will see your hypovascular metastasis best because it gives good contrast with the remaining parenchyma. And hypervascular lesions are less well seen on this phase. Also, depending on institutions or the availability of MRI, we also have recourse to MRI imaging in the diagnosis of HCC, where we would often have multi-phase MRIs. So we often have a T2-weighted FATSAT protocol along with a multi-phased T1 weighted imaging with gadolinium enhancement, a diffusion restriction phase, and an in-and-oppose phase. And more specifically, we have hepatobiliary phase agents, which have contrast excretion within the biliary tree, as well as here you can see the hyperintense parenchyma and hypointense vascularity of the normal liver structure. Some more terminology. So in LIRADS, we do not use the word lesion because the word lesion can often imply only a mass. So a mass classically is seen on more than one phase, whereas the term observation encompasses all other abnormalities that look distinct compared to the liver parenchyma. So this will include what we call pseudo-lesions, which are often due to hepatic perfusion alterations, and they are classically peripherally located, can be geographic or wedge-shaped, and are not typically seen in more than one phase imaging. The observation can be either hepatocellular in origin, but can also be non-hepatocellular in origin, such as intrahepatic cholangiocarcinoma. So when did LIRADS come about? LIRADS was developed as a prototype in the early 2000s, actually in 2006, by the University of California, San Diego Department of Radiology and the Thomas Jefferson University Medical College as a means to standardize the reporting of HCC. But the ACR, the American College of Radiology, got involved a couple of years later, and the steering committee started working on it to refine it as a more structured algorithm that can be released formally internationally. And it was thus released in 2011 and has had multiple revisions since. The last version that we are currently using is the 2018 version, and it has been translated in multiple languages to be used across the globe. The key benefit is to accurately convey the diagnostic impression of the radiologist and to guide clinicians on management. And I called it the 4 C's. So the main pillars of LIRADS is to provide clarity, to facilitate communication between clinicians, for data capture, to promote research so that we can compile data in a uniform, standardized way across institutions, and consistency, to be able to provide longitudinal reporting throughout a patient's history pre and post-treatment, and also between institutions and between patients to be able to compare data and compare management strategies. So this is an example of a templated report, which we should all be aiming to write and to be interpreting as clinicians. So we all want to see at the end an overall LIRADS category, which I will be telling you more about now. So LIRADS provides a stepwise approach in providing different categories, the lowest category favoring benign disease, LR1, and LR5 favors malignancy, specifically for HCC. We've got another criteria called LRM, which is more geared towards malignancy, includes HCC, but is not specific for HCC. And when there is vascular invasive disease or tumor in vein, it's called LRTIV. So according to the table below, you can see that the LR5 criteria has the highest overall probability for HCC, making it the most specific for HCC, and a 97% probability of overall malignancy. And in a radiology article, in the article published this year by Radiology by Victoria Cherniak and al., you can clearly see in red that LR5, when a tumor is assigned or an observation is assigned an LR5 criteria, it carries the highest overall probabilistic figures of 95% and 96% for overall malignancy. So this is very specific for HCC. In terms of different algorithms, there are different pathways and different algorithms to apply, whether the observation has been untreated, whether an observation is treated, whether we're just doing screening and surveillance, or whether we are in an institution where there is no access to CT or MR, but we have access to contrast-enhanced ultrasound, which can also be used for diagnosis. So the diagnostic population for LIRADS meets very stringent criteria. So it's geared towards high-risk patients for HCC, so as to be able to carry the highest positive predictive value for the diagnosis of HCC. And the inclusion criteria is for adults of 18 and above, and adults who are cirrhotic, with certain exceptions, as I will go through just now. Chronic hepatitis B patients without necessarily having cirrhosis in the background. Patients with prior or current histories of HCC, whether they are on treatment patients or whether they are liver transplant candidates. But as I mentioned, some cirrhotic livers have been excluded in the LIRADS criteria, and these are vascular disorders with a propensity, sorry for the spelling error here, with a propensity to form benign nodules that can be mistaken for HCC. For example, chronic vascular outflow obstruction scenarios, for instance, in the setting of congestive cardiac failure, in the setting of Budd-Chiari. Other instances would be the chronic sinusoidal obstruction of diffuse nodular regenerative hyperplasia, or inflow obstructions where you have a congenitally absent portal vein, or hereditary hemorrhagic telangiectasia. So in these vascular conditions, LIRADS is not indicated. And why is it that we focus on adults more than 18 years old? So LIRADS is not applicable to children or to patients under the age of 18. This is because of poor pretest probability of HCC in children, because of the low prevalence of HCC, because including children will limit the specificity of LIRADS for hepatocellular carcinoma, and that's why it's not included. So important to mention here is that when assessing a patient for the presence of cirrhosis, we have to be mindful of conditions that are pseudo-cirrhotic, and where you will have an overall macronodular appearance of the liver due to multiple hepatic metastases or capsular retraction. And the most common cause of this in our setting is treated breast carcinoma. But you also have a differential of capsular retraction, which includes mass-forming cholangiocarcinoma, fibrolamellar HCC, and epithelioid hemangioendothelioma and confluent hepatic fibrosis. So in these instances, you should be mindful to call these lesions, these livers, cirrhotic. So the major factors for HCC on LIRADS, I mentioned a few already, but we essentially look for non-rim, meaning the whole lesion, non-rim arterial phase hyperenhancement. You can see that the lesion is uniformly enhancing on arterial phase. So the enhancement is relative to the background liver parenchyma, so it needs to be higher compared to the background liver. And we also look for non-peripheral washout, compared to the background liver parenchyma, where the liver nodule is appearing hypodense. On delayed phase, a pseudocapsule can be seen, which is enhancing here. And typically this is a little bit more conspicuous than the normal thin fibrous capsule that you can see around background regenerative nodules. The size of the lesion is important in the LIRADS criteria, as I will come to just now. And important to measure here is to include the capsule whilst measuring the lesion. So it's outer margin to outer margin. And the threshold growth, we are looking at a growth of at least 50% or more in a span of less than 6 months. And eventually we come down to this table, who a lot of you might have seen before, is a definite category for either benign disease, LR1 and LR2. So if it's definitely benign, it's LR1, and if it's definitely HCC, it's LR5. And you have these intermediate classifications here. So LRM would be for a malignant lesion, but not necessarily HCC. And in fact, when you go down to the lower part of the table, we use these major features, as I described just now, to be able to further define the risk of HCC. The easiest way to look at it is if a lesion is non-arterial phase enhancing, so a lesion is not taking up contrast at all in the arterial phase. If the lesion is small with no major factors, this is given a LIRADS 3 criteria. And if you have 2 or more major factors, it's a LIRADS 4. And if it's a big lesion which is not enhancing, it would be a LIRADS 4 criteria. And as soon as you progress to an arterial phase enhancing lesion, a lesion more than 10 millimeters with 2 major risk factors goes straight to a LIRADS 5 criteria. And this is what recently changed in the 2018 version of the LIRADS algorithm, is that if you have an intermediate size lesion, 10 to 19 millimeters, and if you have only a capsule as a major factor, you will give it a LIRADS 4. But if you have either non-peripheral washout or threshold growth within your 6-month period, you would give it straight a LIRADS 5 criteria, even if it's not more than 20 millimeters. So optional features are what we call ancillary features, and these are optional imaging criteria that can be used in conjunction with these major findings to be applied at the radiologist's discretion. It's not essentially meant to upgrade through several categories your observation, but essentially it tries to give more of a refined probability of the lesion being HCC or a benign lesion as opposed to a malignant lesion only. What I mean to say is that if the presence of any of these features are seen, these would favor an HCC, and you can bump up a lesion, for instance, from a LIRADS 3 to a LIRADS 4, but LIRADS specifically mentions that a lesion cannot be upgraded from LIRADS 4 to LIRADS 5 based on the presence of either of these. A summary of this would be this diagram. So you can essentially either upgrade a lesion only 1 step at a time, like here, but you cannot go from a LIRADS 4 to a LIRADS 5. You can downgrade by 1 category at a time, but it's essentially you downgrade by only 1 category. So that's essentially what the ancillary features are used for. And you can have a look at the different types of features. For HCC, we will classically look at a nodule, a mosaic architecture, the presence of intralesional blood or fat, and the presence of a non-enhancing capsule to make us think more of HCC as opposed to another malignancy. So the choice of imaging, it really depends on the institution and the availability of resources. Some settings may not be privileged to have a CT scan machine or an MRI. But when you do have an MRI and you do have hepatobiliary phase agents, this enables detection of often small non-hypervascular cancers, non-arterialized cancers in the hepatobiliary phase, and therefore it's more sensitive to these small lesions, whereas extracellular phase agents have better specificity for larger lesions. LIRADS, however, doesn't endorse or recommend any particular imaging methods, but gives guidelines on the techniques, terminology, interpretation, and reporting of these lesions. So ultrasound LIRADS, as you can see here, is classically used in surveillance in order to limit ionizing radiation in this population. And highlighted here are the type of patients that would, according to the AASLT 2018 criteria, would require surveillance. And the contrast enhanced ultrasound LIRADS criteria also have specific algorithms and criteria to define a lesion as a high risk for hepatocellular carcinoma. Coming to the LRM criteria, so this would target more the targetoid or non-targetoid masses that we will see with one or more of these following findings, either have infiltrative appearance on imaging, marked diffusion restriction, intralesional necrosis, or any other feature that would suggest a malignancy, be it or not HCC. So it's not specific for HCC, and even one of these features can prompt one to upgrade a lesion to an LRM criteria. There's no lesional size requirement, and perhaps rim arterial phase enhancement is the most commonly seen feature. So just a few pictures to show you what that would look like. So in this, I've given you CT and MRI images. So this would look like typical rim enhancement of the lesion with peripheral washout, as you can see better on the MRI imaging here. So it's washing out only in the periphery. And there's delayed central enhancement, which is another criteria, and diffusion restriction marked in a concentric pattern here. So on these images, you can see there's rim enhancement of this lesion on the arterial phase study, which is not washing out on the portovenous phase. And as opposed to a capsule, you can see the thickness of it. It's more thicker and nodular and irregular than you would expect a capsule to be. And in this instance, this was rim enhancement in intrahepatic cholangiocarcinoma. So the proposed addition to the existing 2018 criteria would be to, if there is no, if the lesion is not classically in keeping with an LR5 lesion, then you would, if there's any infiltrative appearance, necrosis, or marked diffusion restriction, you can go straight to classify the lesion as an LRM criteria. So what about tumor in vein? This refers to the unequivocal presence of an enhancing soft tissue mass in the vein, regardless of the presence or not of a parenchymal mass. And you would often see an occluded vein with ill-defined walls, marked restriction diffusion, and heterogeneous vein enhancement, which is not in keeping with artifact. As you can see in this arterial phase CT, there is irregular enhancement, heterogeneous enhancement of the portal vein, which is not ascribed to artifact. And on the portovenous vein phase of the same patient, you can now better appreciate the filling defect with a nodular, ill-defined appearance of the portal vein, which is in keeping with tumoral thrombosis. So for ultrasound, you would expect to see enhancement on a contrast phase ultrasound, and on Doppler, you might see internal Doppler flow within a venous clot to make you suspicious for tumor within a vein. And some more clarity, what happens if you have multiple multifocal HCC with multiple lesions? So in the setting of more than, like, for example, innumerable lesions, you would categorize the 5 lesions with the highest LIRADS scores, and these would be reported individually, such as these here, and the smaller lesions can be reported in aggregate and given a summative assessment. But the 5 biggest lesions will be followed up in longitudinal reporting and will be classified individually. And what if it's infiltrative HCC, which often can look very much like hypervascular metastasis, diffuse metastasis, or liver, which is filled with regenerative nodules? So in these cases, like, you would have to look at the enhancement patterns. For example, in this case here, you can see there's enhancement in the arterial phase that is classically washing out on portovenous phase with the appearance of pseudocapsules and with marked restriction diffusion on the diffusion restriction imaging. So in these instances where there is classical infiltrative tumor with the appearance of multifocal HCC, you would give a final overall assessment that this is widespread HCC involving all segments of the liver, as giving an individual LIRADS criteria is impossible in the setting of widespread disease. So ultimately, as soon as we've got a LIRADS criteria, we go down to the management recommendations. So as you can see here, if the lesion is non-categorizable, the patient needs to have an alternative diagnostic imaging and return to imaging in less than 3 months. If there is no observation, the patient returns to routine surveillance. But if there is benign lesions, so 100% benign probability of a benign lesion, they would also return to surveillance. Where there is clear-cut confirmation of HCC or LIRADS 5, we proceed to multidisciplinary discussions to have consensus on management. And when there is any doubt about the existence of HCC, we would proceed to discussion to include biopsy or non-biopsy. I will now be focusing our attention on some special populations that we encounter in the management of HCC. So I will be talking about hypervascular HCCs, sub-centimeter HCCs, pregnancy, and the bleeding HCC. So 50 to 70% of pathologically biopsy-proven HCC meet LR5 criteria, which is quite specific. But 80% of all HCCs can be quite small, and they are likely to be well differentiated and have lower incidence of microvascular invasion, which reduces the sensitivity of LIRADS 5 in these cases. And as per the latest LIRADS version 2018, there is no definitive diagnostic criteria for HCC when there is no arterial phase hyperenhancement. So hypovascular HCCs may not be accurately picked up by the LIRADS algorithm. And for smaller lesions, it's even more difficult for these lesions, even if they are demonstrating all major features, to categorize these as LIRADS 5, because as you can remember, we're looking at lesions more than 10 to 19 millimeters with major criteria, or lesions more than 20 millimeters with arterial phase hyperenhancement. So with sub-centimeter lesions, biopsy is often also impractical, as we cannot biopsy all small nodules, and these are usually followed. And whilst survival of patients with HCCs of less than 10 millimeters has been reported when managed by watchful waiting versus immediate treatment, we found similar survival rates. However, there is also the risk of missing those very aggressive small sub-centimeter HCCs, which have the risk of converting to an aggressive multifocal HCC within the follow-up period. So that's a definite caveat. In pregnancy, there's no separate LIRADS criteria for the pregnant patient, but we have clear etiologies of gestational immunosuppression in the setting of endemic chronic hepatitis B infection that will predispose one to an increased risk, and the hormonal milieu may just add to it. The important considerations in the absence of a LIRADS criteria would be to prioritize non-ionizing radiation studies, such as contrast enhanced ultrasound, or to prioritize ultrasound for the diagnosis of this lesion. And when there's high risk of the lesion being HCC, we would proceed to do cross-sectional imaging, which would be an MRI, but we have to be mindful of the risk of gadolinium to the fetus and the relative safety of primo-vis versus gadolinium. And the risk is essentially due to the immature blood-brain barrier of the fetus. In the setting of bleeding HCCs, as we know, hypervascular HCCs are very much likely to bleed. In about 19% of all HCCs, we see bleeding. And this can occur by repeated minor trauma, the presence of superficial lesions, or intratumoral high pressures from thrombosis of draining veins, and in fact, neovascular fragility of all these lesions would predispose to bleeding. But intralesional blood products counts as an ancillary feature and not a major feature, and cannot be used to upgrade from a LIRADS 4 to a LIRADS 5 in isolation, because there's lacking evidence on the specificity for this particular criteria to upgrade directly to an LR5 criteria. But it certainly can be used to favor HCC. If you have a LIRADS 3 lesion, it would make the lesion be upgraded from a LIRADS 3 to a LIRADS 4. Moving on to the treatment algorithms. So the treatment algorithms apply to multiphase CT or MR and essentially aims to detect tumor viability after local regional therapy. And the categories are assigned on a lesion-by-lesion basis and are basically classified on the presence of either arterial phase and hyperenhancement or washout or enhancement similar to pre-treatment imaging. And it encompasses both percutaneous therapies, transcatheter therapies such as TACE or external beam radiation therapies. The aim again is to give certain defined categories such as LIRADS non-evaluable, non-viable, equivocal, and viable, the last one being the LIRADS criteria for viable tumor in a post-treatment HCC that will often require retreatment. And in the algorithm for treatment-specific LIRADS, so we would look at the following criteria. If there is treatment-related parenchymal, treatment-specific enhancement around the tumor, you would call these parenchymal perfusion changes if it's outside and relatively close to a recent treatment. But if you want non-viability, you would expect to see no enhancement at all within the lesion or along the margin, but the presence of nodular thick enhancement within the surgical margin of resection and within the tumor itself would account as post-treatment arterial phase and hyperenhancement. And the presence of washout as well on its own is enough to call, nodular washout is enough to call this viable tumor. And even if there is no washout, but you see an enhancement, which is similar to pre-treatment imaging, this counts as viable tumor as well. So special consideration. So systemic therapies are not applicable here. So we cannot use these patients who are purely on systemic therapies. For post-surgical resection, you can apply LIRADS TR to the lesion up to the resection margin. For the rest of the liver, you will use the LIRADS diagnostic algorithms for treatment for observations that have not undergone treatment yet. And if there is combined systemic therapies and local regional treatment, you would apply LIRADS treatment algorithm at the discretion of the interpreting radiologist. So is there an ideal single diagnostic system for all of us out there? So to tailor a LIRADS to every single patient or every single HCC that we come across can be very challenging, because HCC presents in infinite ways with multiple lesions often and requires often a lot of challenges in reporting with longitudinal lesion tracking, some lesions getting treatment, some lesions not getting treatment. There's variable tumor biology across the globe with geographical differences within cirrhotic versus non-cirrhotic HCCs. And moreover, in high resource settings versus low resource settings, the management is often very, very different. In high resource setting, the presence of poor liver reserve in the setting of cirrhosis favors transplantation, where you want a very specific diagnosis of HCC for organ transplantation and allocation, whereas in low resource setting, the emphasis is on resection and high pickup of lesion because of the patients being younger with better liver reserves, where resection is preferred. So you can already see that the requirements from LIRADS differs according to the settings. So the future directions for LIRADS would be to define new criteria to enable us to better diagnose HCCs which have no arterial phase hyperenhancement. We need more research to define diagnostic criteria for sub-centimeter HCCs that are also high risk and that may grow rapidly during follow-up time, and to have a lower size threshold, maybe, for example, 15 millimeters, to improve the sensitivity pickup of HCCs without sacrificing specificity. As we know in the table, we are looking at 20 millimeters as the threshold. And as I mentioned, some of these gaps are present, but we are moving in a direction to unify global systems. It has been implemented in the Northern American American College of Radiology guidelines already, and we are moving more forward towards user-friendly structured reporting to facilitate interdisciplinary communications. And the probabilities of HCC now are also being assessed at a metabolomic level and a radiomics level. And we are using circulating biomarkers to help improve the positive predictive value of lesions labeled as LIRADS 5 lesions. In concluding remarks, I would just like to say that HCC remains a leading malignancy in sub-Saharan Africa. The LIRADS 5 criteria can achieve a very high specificity and positive predictive value for HCC to enable clinicians to manage definite HCCs without biopsying these lesions. And ongoing revisions are happening to continually improve the existing LIRADS, and hopefully in the future we'll see a more individualized and probabilistic approach to individual HCCs by taking clinical factors and biomarkers into account rather than just looking at just the presence of cirrhosis on HCC imaging. And deep machine learning is here to help us to do that. And at our institution, we are doing AI work in progress. We are combining biomarkers of HCCs, and data has been sent and is in the process. We are working with the ICGB, which is the International Cancer Genetics Institute of New Delhi. And we are combining data to look at the radiomics and metabolomics of HCC. So that's my references for the talk, and that's me. Thank you very much. Thank you for your attention.
Thank you very much, Dr. Segobin. That was an excellent overview. And I think it shows how complex LIRADS is, but it's really nice when, you know, as a surgeon or someone who's treating an HCC, that you get a report where the LIRADS system has been used properly, because you know, it allows you to sort of make an informed decision on how to treat these things, and I think it avoids unnecessary biopsies. Are there any questions? I think it's a good time for us to have questions. If anyone has questions, if they can just raise your hand, or you can put them in the chat.
Mark, I see there's one question in the chat.
Yeah. Is MRI hypersensitivity quantified by number as in CT, Hounsfield units, or is it subjective? Rajshree?
Yes. So so for MRI, we're looking at the hyperintensity of the lesions and not Hounsfield units. So you cannot compare the two here. And if I understand the question properly, the question is about comparing Hounsfield units on the triple phase CT versus on the MRI.
Can you quantify it with a number, or can you actually measure it, you know, on the MRI, or is it just a subjective thing?
So we would use the Hounsfield unit to quantify more on the CT.
Okay, but is there not another measurement that you can use apart from Hounsfield units on the MRI to actually like get a number where you can say it's definitely hyper-enhancing or washout, or is it just a subjective thing?
You can definitely do that to look at the soft tissue and the difference in the parenchyma. But my experience is that we classically use it more in the in CT imaging.
Okay, and another thing. So another thing is how do you say hypertension? This is the follow on from the question. How do you say hyperintensivity is mild, moderate, or severe? Is that just subjective?
I would presume it's more subjective. I cannot imagine any time when you would compare it to the background liver parenchyma, and you would also look at your different phases and compare the hyperintensity to the other previous possible imaging, whether there is increase in hyperintensity of a lesion compared to a previous study of the same lesion. So in that case, in longitudinal reporting, you can subjectively compare. But if you have a de novo lesion in a in a new patient, it would be very difficult to quantify if the lesion is how avidly this lesion is appearing as hyperintense compared to the liver parenchyma.
Okay, and then just a question for me, just with regards to tumor in vein. So if it meets those criteria, that's the same as a LIRAD 5. Essentially, it's definitely an HCC. If you've got a tumor in the vein that's continuous with the lesion and it's enhancing, is that correct?
Yes.
Yeah. Okay. There's another question: is contrast enhanced ultrasound superior to CT when applying LIRADS?
I must say I'm not too sure about that, but maybe one of our professors in radiology would like to comment on this. Our institution, we do very little of contrast enhanced ultrasound. The sensitivity with respect to CT, I'm not very much aware about the actual figures. But maybe, I don't know if Prof. Benningfield is on the meeting, if he can advise.
I can just chip in here, Rajshree. I think the problem is we don't have any experience with that because the ultrasound contrast is not registered in South Africa. And I don't think, if I'm not mistaken, anywhere in Africa. So, the dynamics of the contrast is a little bit the same as you would have for any intravascular contrast.
Yeah, definitely. We're not doing any contrast enhanced ultrasound, at least in South Africa, as far as I know.
And then, does the limitation of venous obstruction apply to portal thrombus caused by tumor itself, or only the obstruction caused by another reason? I would think it's. I think a portal vein thrombosis isn't. You can still use the LIRADS system, and in that case, you'd be dealing with a tumor in vein situation. Yeah,
and it would, like I showed in the previous slide, it would also look at the walls of the vein. So irregular appearance of the walls of the vein would make that look more like tumor thrombus. Tumor in vein versus like the classical intravein thrombosis from other causes. So the irregular.
And if I'm not mistaken, when you can't use the LIRADS when the cause of the liver disease is a vascular problem such as Budd-Chiari, but when you have a portal vein thrombosis due to tumor or something like that, that's not actually the cause of the underlying liver disease.
No.
Okay, I think
it's cirrhosis. If the liver is cirrhotic from Budd-Chiari, then you cannot use LIRADS. But if there is thrombosis as a consequence of the tumor, if there is thrombosis, then you can use tumor in vein.
Okay, so we've really only got 10 minutes left. So I think we're probably going to have time for one case. So Sanju, I don't know if you want to choose which one we're going to do. Should we go according to the order of the list? Okay, I think that's what we'll do then. So
they just have to unmute in the library there. Here we go. Mohammed, you can go ahead.
Can you hear me, Prof?
Yes.
Okay.
But do you want to share? Yeah, we can see that.
Okay, cool. Good evening, everyone. My name is Muhammad. I'm one of the surgical registrars at the UCT. So I'm presenting a case, it's quite an interesting one. So Mr. X is a 42 years old male. He's already positive on treatment. His CD4 count is 143. Newly diagnosed with a hepatitis B. His viral load was 443 with a MEM 16. So he presented to us in July 2023 with 2 months history of loss of weight and nausea and vomiting. Examination wise, his abdomen was soft, distended, but there was a mass occupying fullness. Lab wise, his AFP values was 31, CA99 was 6, and CEA was 1. Total BDs were 15, and INR was 1.4. So at that stage during admission, we did do a CT scan, and it showed a large pedunculated segment 2-3 lesion, which was in keeping with HCC. Since he presented initially with gastric outlet obstruction, so having nausea and vomiting and unable to tolerate anything orally, we did do a G-scope for him. So he, in G-scope, he had a very dilated stomach with the external compression of D1, D2. So we started him on TPN and for optimization for surgery. Then, okay. So he stayed there for 10 days for on TPN for nutrition. And then the day before the surgery, the night before the surgery, he started to become sick. He dropped his HB to 5, started to become hypotensive. And so we did research, gave him bloods, and did repeat the immediate CT scan when he was stabilized. So this is the CT scan which was done. So the picture on the left side, yeah, as you can see, there's a very dilated stomach, and there's a free fluid in the abdomen, which was the house-filled unit was in keeping with blood actually. And the CT scan on the right side, you can see the large pedunculated tumor, which was very hypervascular with a lot of feeding vessels. So he was taken to theater, had acute abdomen, taken to theater, a lab was done, had hemoperitoneum, a large pedunculated mass was with area of necrosis. He underwent a left hepatectomy. The post-op was uneventful and he was discharged at day 5. So his follow-up histology showed moderately differentiated HCC, which had a clear margins of pathological T2 and 0 M0. He came for follow-up post-op 1 month. We decided during our MDTs that he should go for a test, which he went. And during the test period, actually, and the scans, it showed that he has a new hypodense lesion, which was found. Okay, so just quickly, it's a case series which was done in Nigeria by Muhammad et al. During the period of 1975 to 1987. He had total of 35 patients, 26 were males and 9 were females. Mean age was 44. 70% of this patient, of the 35 patients, were HPV positive, and 94% had liver cirrhosis, 23% had metastasis at presentation. So they also presented as spontaneously ruptured HCC. The management where 77% of them had wedge resection, 14% had the artery ligated, and 9% had formal liver resection. So the results following up them for 6 months, there was a high mortality rate. 46% actually died during the first 35 days, with a mean survival was of only 22 days. The 19 people who were discharged home, 7 were seen at 3 months and only 2 were seen at 6 months. The remaining were assumed had passed away. So on conclusion, most of the patients who presented with spontaneously ruptured HCC presented in advanced stage. Thus preventing of rupture will depend on early diagnosis. Acute presentation of spontaneous bleeding HCC, especially if they present with hypotension or a low HB, has a high mortality. So a timely diagnosis and management of HCC is needed to prevent this serious complication and high mortality. Thank you.
Thanks, Mohammed. Great presentation. I think this case highlights a few things. It's first of all, how advanced the HCCs are that present to us. And this patient had gastric outlet obstruction and this massive mass, but also how you can often actually resect these lesions because the patients are quite young with good performance statuses and often have non-cirrhotic livers. The other thing that was interesting about this case, and unfortunately I think Dale's left the meeting, is it was the first patient that we've done an adjuvant TACE on. So there is increasing evidence to support the use of adjuvant TACE after a liver resection, and that was when we picked up the lesion. That's when we picked up the lesion that popped up, and I think this patient probably did benefit from having another TACE, and from having the TACE, and we'll follow them up, and potentially we might be able to resect that lesion or ablate it later. Yeah. Anyway, I'd like to, I'm not sure if there's any other questions. If there are, if you can just raise your hand, or once again, you can put it in the chat. I'm just trying to get the chat up. If not, I'd like to thank everyone. This is the last HCC Gecko meeting for the year. And I'd like to thank the speakers and the ECHO University of New Mexico and ECHO India team. The recordings of this are available on the Gastro Foundation website. Thank you to the Gastro Foundation for supporting this, to the presenters, and also to the sponsors. And next week, the talk will be on patient blood management. Thank you very much, everyone.
Thanks, Mark.